So I want to talk just a little bit about the Ohio Medicaid journey to get to the point where we can answer some critical questions about how to inform policy, engage community partners, and then also hopefully foster market competitions as well to leverage what the market has to offer for the Medicaid patients. So starting about 5 years ago, there has been a large shift within the Ohio Medicaid organization where rather than having independent analysts kind of distributed throughout the entire agency, we started to consolidate some of the resources into central teams. So we've progressed to a point where we have a hybrid model where we have an entity that's underneath me for the data governance and analytics that handles all kind of population health questions and department at large questions, and then embedded organizations or analysts within long-term care support services or budget forecasting, so some of the smaller pieces that aren't overarching for the entire agency. And part of that shift was to provide more consistent answers rather than asking, we'd have a director who would ask a question and then 3 analysts would provide a response and they'd all be different and they'd all be published, and then somebody would, they'd all end up in the paper, and then there would be questions and concerns and we would not look as smart as we actually thought we were. Part of the problem also was the IT component of it. Individual analysts are trying to do their best to answer questions as quickly as possible and as accurately as possible. And so we ended up we had these shadow IT departments that were being developed where there were little pockets of data stored everywhere and could answer questions efficiently, but sometimes very differently depending on how it was asked and how it was interpreted. So we started to consolidate all of that information, building into our enterprise data warehouse, and where we would then start to create views and models for the eligibility space or the pharmacy space. And so every single question, no matter what unit you're a part of, you know this is the exact tool to go to. It's all staged in the same area, and we have a much stronger governance structure around how that is stored and how that is used. So a little bit of boring background to get to where we are right now, but because we have that strong governance, privacy, and security framework under which all the data is collected, disseminated, and used to produce results, we now very quickly can do more than just counts of what is happening in our state at any particular point in time. There are lots of business intelligence tools that will sit on top of data, and if you want to know how many people have this condition, you can get that type of information very quickly. But from an analyst perspective, being able to dig into the data, find statistical significance, to be able to see trends over time, to see shifts in population relative to other concerns, that things that are actually interesting to analysts, that takes much more sophisticated tools than a standard business intelligence type tool sitting on top of a warehouse. So I want to show just a few different slides. I won't necessarily spend a ton of time on each of these, but just to give some ideas. With Ohio relative to the opioid crisis and behavioral health in general, starting about a year ago, we went through a behavioral health transition where we revamped how the entire program was done throughout the state. And in order to see if the effect, if we had the intended effect, we had to measure both the types of services that were being provided before, as well as the types of services that we wanted them to shift through. And we needed to make sure that the type of care that was being provided not only was billed consistently and that the number of patients were still being there, but that they received consistent care and consistent outcomes. So again, these are not just a simple count, but you have to be able to track trends over time. So this is just one of the dashboards that we had created in its actual form. It's an interactive dashboard where you can pull up all of the different variables and see how they interact over time. But you can see certain types of services, the CPST codes relative to the TBS group. We wanted to see trends shifting in the use of one versus the other, and we were able to see that our policies were starting to have the intended effect. Let's see. We also wanted to look to make sure that the number of services being received and the expenditures, that the impact that we had was not having a negative result on being able to get access to services. And then as we're looking at the total Medicaid consumers that were receiving services, you'll notice a dip in the July timeframe. So as we were carving in the behavioral health. When we initially did the behavioral health transformation, it was done at fee-for-service. Then after 6 months, it was then transitioned into managed care. And because we were monitoring the entire time, as soon as there was a dip in the number of services being received, we were able to see that, identify that. We were able to bring the community partners together. We were having weekly, sometimes more, meetings with all of the managed care plans, the various community partners, physician groups, Medicaid, where we were going through what was causing difficulties in access to that information. So from a policy standpoint, you start off with the design. We were able to model that. The data was collected in a way that we were able to monitor continuously, and then as problems were coming up, we could kind of work to produce solutions. The last dip at that end is just claims run out. It's not another problem. It's just not reported data at the time we made this particular chart. Also from a patient experience, Dr. Owens, one of the things that you had brought up is making sure that people were, being cared for as policies were being put into place. And throughout any particular period of time, there are always going to be facilities that are closing. Not necessarily in relationship to our policies, but that's just the nature of business. But these are our patients, and we want to make sure that they are receiving the care that is necessary. So as different entities were closing down, we were able to then gather up the number of members that were being received and then start to track whether or not they were receiving consistent care through that transition period. So again, this is a chart that could then be continually monitored and updated as we were going through that transition period. Now, every Medicaid state, especially those that have a high number of managed care members, so in Ohio it's just over 90%, there's always going to be a delay between when you receive claims relative to those service dates. So being able to monitor what's happening right now becomes challenging. So what we set up was within the behavioral health space for the drugs, those are point in time. At the same time that a sale is being made, we collect that information immediately. So that became the point that we were going to measure to make sure that individuals were at least receiving the drugs that they were looking for. So if you get to April, May, you can see the transition with any healthcare visit, dropping from 91 to 86, 70 to 47, 64 to 34, and that could potentially indicate that there's a concern that these individuals are not transitioning and getting the care that they need from one close facility to another. But because we were able to think through what kind of innovation can we think up to monitor in a more effective way, more real time, the prescriptions gave us a way to track at least as a proxy for whether or not they were getting the care that they needed in that critical period. Governor DeWine has also put an enormous emphasis on multi-system youth and on the foster and adoption assistance aid categories for people who receive Medicaid services. And as we're looking at how to provide services for them and transitioning over time, we have a number of dashboards that we've been able to create to help focus our attention into the areas where both the need from a foster care adoption assistance is present, as well as the convergence of the higher inpatient stays or other medical needs. So going to jump out to kind of engaging the community. So this is one of the dashboards that we have created. It's interactive for public consumption. And the intent is and I think everybody probably faces similar concerns, where you have media requests or senators or schools or community partners who are trying to do their best to answer questions, to inform the public about what's going on. But every time a question is asked to one of the analysts in our department, that takes time away from policy decisions that or support that they're able to provide. So we went over the course of about 2 years, kind of collected up all the questions that were being asked, and then based on those questions, we created a dashboard that would then answer those live, kind of real time. It's refreshed on a monthly basis. We have information about, it tracks over time, so if, you can look for the last 13 months. You can do county versus zip code. We're adding in schools and other regional types of maps, whether it's a legislative district or Tableau has to be upgraded one more time before we can add some more sophisticated levels of geographic analysis. But the types of caseload, whether it's an ABD, CFC, expansion population, women of reproductive age, race, ethnicity. So all of these different types of questions that we get asked relative to who's in fee-for-service, total enrollment, age breakdowns, and we also have information on Medicaid expenditures. This is just one of the different views. So if you're looking at physicians versus pharmacies, you can see where there are outsized costs relative to the number of patients or the number of claims. Some of those are totally legitimate, right? Inpatient stays or long-term care services are going to have higher costs relative to others, but it also indicates, where there may be policy areas that could focus on moving those together to gain some more efficiencies. And in this part, I wanted to show this just as an example to the care from a privacy perspective. Anytime you start putting information out publicly, there's a potential concern that you're going to expose personally identifying information about individuals in the Medicaid space, and that is protected, and we need to make sure that that is safe. So if as you zoom in, I just kind of want you to notice with Brown County and what happens on the side with the age, as additional pieces are added to each one of those filters, the age, certain categories are going to drop off. So without we programmed it into the Tableau interface so that as soon as you drop below a particular threshold, those categories drop out so that no one will be identified based on the searching that's done. So all of that privacy, the security is incorporated into the solution that was presented to our community partners. So now when we have individuals calling up and they're wanting to open up hospitals in a particular area or provide behavioral health services, they can go to this type of a chart or this type of a dashboard. They can go to a particular county, they can see who's receiving services, they can use that information to help inform some of those public decisions. Let's see, how am I doing on time? You're doing okay. Okay, great. So this section on kind of fostering market competition, we've in Ohio, I don't know if anyone else pays attention to Ohio news from a PBM perspective, but Ohio's Medicaid program and the PBMs and the profits that PBMs were taking in the pharmacy space was big news for a number of months. There were dozens of articles that were written in the Dispatch. So, from a policy standpoint, what is it that we as the Medicaid program are able to, understand, model, research, and then produce information to the public so that they can be assured that the taxpayer dollars are being used as efficiently as possible to provide the necessary services. This is the first of the dashboards that we put out. It's based on both administrative data and on survey information that is coming back from the plans about exactly how much money is being spent to administer the pharmacy benefit. So we have, the total number of unique members for a particular quarter, what the ingredient costs were, how much the state was paying to administer the program, both from the pharmacy, from the managed care perspective, as well as the PBMs. So all of that information is available. You kind of dig down into, as well as looking at the brands versus generics and specialties, so that you can have an idea of where the costs are at. We're also looking at the accuracy in the information that is being provided. It's a little bit of public shaming for some of our entities, our managed care organizations. We have to have accurate data. We know that because of claims lag, if we're in that 2% to 3% range, we're pretty good, but anything beyond that signals that we need to do more work to get the data in more quickly. All of that is published and available for people to see, along with a very detailed report about the findings. There are some additional pieces of information that we're starting to add now as well. This is just the start of some dashboards, where individual pharmacies or individual providers would be able to log into a portal. They would be able to put in their recipient ID or their Medicaid ID or their MPI, and then start to receive information that we know about the the overall market for them that they may be able to use to help improve services. So trends in the number of prescriptions that they're receiving at different locations, impacts before and after policy decisions that we've made, the number of scripts per patient, where for cohorts of people coming in, where they have are your customers coming back to you, or are they going somewhere else within the Medicaid space? We only know the Medicaid data, of course, where they could be able to trend that over time. And the idea here is to at least provide as much information as we can about what is collected with Medicaid to be able to help all of our partners, whether they are the business professionals or hospitals or community partners, to be able to have the information they need to be able to work together to provide the best service for the Medicaid members in Ohio. So I think I'm at my time. Thank you very much, and appreciate you as an audience listening. Thank you.